It is really a great privilege to be here. Privileged to be in a new learning center. Tonight I'm going to share with you really many years of working in interprofessional education for patient-centered collaborative practice and thinking about the real issues that we're confronted with as we attempt to articulate clearly why it is that this is anything different from anything that we have done so far. So this was Abram Flexner. At the beginning of the last century, 1912, Flexner was invited by Carnegie, not the foundation, it was a different organization, but it became the foundation. He was asked to look at all of the medical schools in the United States and Canada, and to write a report about what should be done about the future of medical education in the United States and Canada. Flexner made three major recommendations, two of which are salutary. The first was to get rid of the proprietary schools of medicine in operation. He said, take them out of existence immediately. These were the barbershop schools, old-fashioned surgery that was done off the back of a wagon and in a place with a barbershop pole outside. He said, get rid of them. This is not medicine, should not be counted as medicine, and in fact it gets in the way of doing real medicine. So that happened tout de suite. Almost immediately those places were closed down. Remember, of course, that in the United States there were, and in Canada, outstanding medical hospitals and medical schools. Hopkins in the United States, for example, McGill in Montreal. So not all things were bad. However, the second recommendation he made was that all the remaining and future schools of medicine should be associated with universities and teaching hospitals. And then finally he said, there should be a nucleus of physicians in each department of a medical school who would receive remuneration for teaching and research. The professionalization of professions has, in many respects, turned the patient into an object of professional attention and observation, rather than the Oslerian ideal of the patient as subject. And you have to think about, why is that? Why has that happened? Well, during the 20th century, we saw the rise of health professional programs from a nucleus of around four: medicine, nursing, social work, which was then almonry, dentistry, which was not quite in there, and pharmacy. Over the course of the 20th century, in Canada, we developed an additional 68 health occupations. And in the United States, the number is somewhere in the order of 254. Now, what they count, I'm not quite sure. But so you get this emergence of health occupations, health professions, who look at medicine and say, we want to be like that. We want to be in the university. We want people who are on faculty, who are doing research, et cetera, et cetera. So it should come as no surprise that the level of understanding of practice between and amongst professions became woefully inadequate. And so what we see is, as the professions developed and developed their guild structure, that guild structure then replicated itself across all of the professions. What it did was to push apart the professional student, the student in training, because there were not opportunities to learn about each other, from each other, and with each other. there is an interesting historical comment about UBC. So Jack McCreary here was a pediatrician before he became Dean of Medicine at UBC. He was one of the pediatricians of the quintuplets, the Dion quintuplets. And he was the guy that hired me, and frequently he put me between rock and hard places and I tried to squeeze out money for something or other. But he said this: all of these diverse members of the health team should be brought together during their undergraduate years, taught by the same teachers, in the same classroom, and on the same patients. 1964. This is a cartoon that we developed in the Canadian Interprofessional Health Collaborative to try to illustrate the problem that we have. I sat on the Committee of Deans for almost 12 years, and it was a fascination to me that every time a new dean came, high on the list of those things to be achieved was a new building. Every new dean wants a new building. But, you know, that's a good thing for the professional group, okay? You build a new building. But as, you know, curriculum got bigger and the amount of information we had increased and the numbers of students got larger, so the building, the Lone Ranger building for X profession, got bigger. Not one nook or cranny could be found in which two or more could gather together in the name of good health to talk about the patient. This is not some make-up campus. This is campuses across North America and across a lot of the rest of the world where we have advanced health care. You cannot imagine a worse environment in which to try to put together interprofessional education for patient-centered collaborative practice. I was struck by the notion that many, many, many of our students have no idea about the determinants of health. Really, no idea. How can you possibly appreciate, you know, what your neighbor who is an X, a Y, or a Z, or an A, or B, or C does if you don't understand clean air, clean water, peace, literacy, are what are the foundations of good health? How can you? And yet, you know, we actually graduate thousands of students out of health programs who don't know that. It's very sad. So what we did was to set up an elective, because as I told you, no electives. He said, well, here's an elective, see if you... That course went from 50 to 500 in a leap, because it's a relatively easy course to put on, right? You get in high-powered, really good people from the public sector, and by the public sector, I don't mean just public health sector, I mean private public, who can talk about issues that they are absolutely familiar with, and which makes the students' eyes go like this. Oh my God, I didn't realize there were so many rats in the sewers. The second thing that we discovered is that people try to teach team dynamics within the healthcare system, and some do a good job of it, and some don't do a good job of it. We wrote a paper about this in 2000, it was published in 2000. What was very clear to us, and I think this is why this has to be a second course that we actually teach, what was very clear to us was that you can teach team-based skills outside of any reference to health. You don't need to talk about health, because if you look at the kinds of stuff which is in behavioral psychology, for instance, there are lots of abstract ways of doing this. The key is for students to understand when they go to a team meeting in a hospital that they should ask some simple questions like, is there an agenda for today? Will somebody take some minutes for this meeting? what do you think the outcomes should be? We bring our people here to learn how to do the job better, not to do the job. That's what we do in healthcare. We bring you into this environment because we want you to learn how to do the job better. There are some very difficult topics, and I'm not sure yet that we've figured out where we should teach these topics, but they should be done in clinical sites as well as on campus. Interpersonal differences, very, very, very important to understand what those are and to have ways of working with that conflict. Fear of change, we all fear change, and how is it that we manage it in a way that is not threatening, either for your job, or for your salary, or for your family, or for the way in which you have organized your workspace within the hospital or within the health system. Stereotypic rivalry, very, 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 very big problem. Begins as a kernel in grade 2. Stereotypes begin very early, and they are incredibly difficult to erase, but we've got to do it. Power, income, and status, everybody recognizes this. This has to do with who you are in the workforce, where you are in the workforce, what your education is, etc. And then language. There's the secret code of every guild. And then, of course, there are secret codes between those who want to share some of the secret codes, but not all of the secret codes. And then, of course, there's gendered language. There is this language difference, and we have to be very sensitive to it, and as yet, we have not really looked at it in the healthcare system. And in order to understand interprofessional, we have to understand the complexity of that interlanguage. And then the third thing that I think we have to think about very carefully in erecting interprofessional education is for our students to understand the sociological, psychological, and legal issues that have to do with practice. I don't know whether your students leave knowing, that registration is because of, legislation is because of, and that scopes of practice is not to include everything in the world that you could possibly think of. Our students, by our I mean our students, have very little idea about sociological, psychological, and legal issues associated with practice. And they need to understand if they're going to work interprofessionally. Let me now give you the definition. Interprofessional education occurs when two or more professions learn about, with, and from each other, enable effective collaboration to improve health outcomes. I want you to note that this is not a sound bite. I also want you to note that there is no hyphen in the word interprofessional. The hyphen in interprofessional is gratuitously placed there by Word, thanks to Microsoft. Interprofessional health education has no hyphen. When I read some new soundbite on my latest Google alert that has a hyphenated interprofessional, I think, I'm not going to post this. These guys haven't read anything yet. All right? So first, get the right word and get the word right. We have to develop the pedagogy both on the campus out there and on this campus about this learning process, about, from, and with. We have to develop that pedagogy. We have to know what it is in a diabetes clinic where we have 6 or 7 different health professional students gathered together, what it is that we want them to learn about each other, what it is we want them to learn from each other, and what we want them to learn with each other. And these are 3 different words. They are not synonyms for the same thing. Then we have to develop institutional supports, a working culture, and an environment. We have to have good governance models for the way in which we're going to do this kind of education, because it's going to go through all of the education that we do. We have to have good personnel policies. We have to recognize that some people are going to be exceptionally good at this, and some are not going to be able to do it. And we have to have policies that are clearly equitable on both sides. We have to be able to share between our institution and this institution some common operating procedures to make this happen. We need to have shared protocols. If we're going to say, oh, this is what you need to do in order to get promotion, tenure, and merit increase at the university, then on the other side, we have to have review procedures which say, you're contributing in a very particular and special way. We're going to put this into our annual reviews. And then we have to have supportive management practices. And by that I mean, you don't expect somebody to sit in an 8x5 space with a table that has one chair and no telephone and say, now get on with IPE. It will not work. Now, we're often asked about when is the best time to do this? When should we engage in interprofessional education? You can do this too early. You can try to introduce students too early to the process of interprofessional. So we talk about exposing students in those first 2 years to literally any kind of team-based care we can find. So by the time they get to this year prior to graduation, when they really are out there doing the job and you know, contributing hugely to the health of the population, that's the time we want to get them immersed in interprofessional exposures, interprofessional interactions. And that's the time that, at the present time, we do not have our hands around. Because that's the time when they come to you and to all of those facilities associated with this facility to learn how to be an X, a Y, or a Z from people who've been doing this for a long time. And I think that this is the golden opportunity. This is where, if you have a group of disparate students come together around, let's say, a chronic disease, you have a huge opportunity to teach the inter piece. Huge. And then once our students graduate, we want to keep them doing this. So provide them with opportunities to learn more, practice differently, etc. So expose, immerse, master is something of our mantra for how to do this. And again, the community plays a huge role in this because that immerse part is here. We don't usually do that kind of work on campus. Problem-based learning. You know, it started just down the road, right? McMaster University. And I think that has huge potential for interprofessional education for collaborative patient-centered practice. Modified problem-based learning, because we want to get our students back to looking at the problem as a group. Exchange-based is useful, and we do this now, debates, seminars, workshops, so that's part of the modification. Action-based, where we do case-based learning, we do a joint research project. So this modified problem-based learning that I'm talking about is not just problem-based learning, but these other ways of bringing around interprofessional education pedagogic pieces that will facilitate, and not only facilitate, will help to sustain the learning that we want to do in order to further interprofessional education. So how do we prepare? First, we have to establish the knowledge base, which is what we're doing. What is the knowledge around interprofessional that we need? We have to acquire new skills. You know, interprofessional is not this. It's not talking past each other and imagining you're interprofessional. Interprofessional is inter, here. What is that? We have to learn what those pieces are, what those skills are, in order to make it work. We have to change our attitude about the way in which we are teaching. And then we have to develop perceptions. Part of what I'm doing in talking to you tonight is to change or to move your perception about interprofessional collaborative practice. Move it, you know. And we've got to change that perception between professions. and then within and between organizations, professional organizations, and then of course with our clients and their caregivers. We have to have that opportunity of the group of health professionals to learn by doing with each other, not just working with their own professional mentor or preceptor. So I think that for the future of interprofessional education and collaborative practice, the locus of care is going to have to be this collaborative learning environment. That is the place where we ensure that every student that comes through here, from whatever agency it is, has more than one, hopefully many opportunities to actually work with each other around a proper patient. We want to build this symbiosis between the health service and the community. That's one way of doing it. We want to make sure that the values that are captured here in vision and mission statements contribute to it. And we want to be sure that when the university is doing its thing in terms of changing its curriculum or whatever, it's being responsive to the community, not telling the community this is what you're going to do. And lastly, we want those students to come out so that they can actually do the job. And I think, just to leave you with this thought, you have to face reality. The challenge of change I come back to. It ought to be remembered that there is nothing more difficult to take in hand, more perilous to conduct, or more uncertain in its success than to take the lead in the introduction of the new order of things. Because the innovator has for enemies all of those who've done well under the old conditions, and lukewarm defenders in those who may do well under the new. I have a feeling we're not in Kansas anymore. It's a new place. All my relations, thank you for your attention. It's late.